Thank you for having me. What a great conference so far. It is my honor to present to you a little bit of what I've learned over the last 6 years in Maine practicing cannabinoid medicine on the front lines. So just an overview of the next 20 minutes, an introduction to my work, and then some of what I've discovered about cannabinoid dosing nuances, including the nonlinear dose response, sensitization and tolerance, bidirectional effects, and then I want to talk a little bit about acidic cannabinoids, which I've been seeing some great results with in my practice, and then I'll end with 3 pediatric seizure cases in kind of the theme of today. So Integrate is the name of my clinic. We started in Manchester, Maine. Now we have 3 practices, 2 in Maine, 1 here in Burlington, Massachusetts. I work with about 16 other medical providers, and together we take care of at least 18,000 patients. Actually, I think it's closer to 20,000 patients now. These are all real patients with real medical conditions. We're not in the business of providing certifications for personal adult use, even though I don't think prohibition is a very good public health policy. In addition to medical cannabis, we practice good medicine, integrative family medicine, osteopathy, which is one of my loves and specialties, functional medicine, mind-body medicine, and more. You can see the age demographic of our practice, so it's mostly adult patients. In Maine, we have distinct qualifying conditions for which we can certify a patient to use cannabis. And so here's the basic demographic, about 72% chronic pain, 13% PTSD, and there's certainly an overlap of people that have comorbid PTSD with chronic pain. And then the rest is pretty much a big mix of many other conditions. But as a clinician, it's an incredible honor to be in a practice where I see such a variety of pathology, and I get to apply all my skills and what I can learn from the primary research and from my clinical experience to help different patients with different conditions. So well, I'll back up for a second. About 2 or 3 years ago, with some of the documentaries on CNN, parents started coming to me requesting that I treat their children with cannabinoids for various neurologic conditions. And at the time, I was basically faced with, and a lot of the clinicians in the room could probably appreciate this, a mom holding up a bottle of tincture and saying, how many drops of this should I be giving to my child? Which is puts a clinician like myself in a very uncomfortable position. What's in that bottle? How potent is it? And so forth. So we did our best to start tested labs, and I believe that we're the only medical practice in the world that does cannabinoid medicine and has in-house analytics of the medicine that patients are using. This allows us to discover new things about what's working and what's not working, and also to really fine-tune the dosing and understand what's happening there. So we're making new discoveries all the time, and some of our best discoveries come from people's mistakes. In the words of someone I admire a lot, Bob Ross, the TV painter with the afro, he said, there's no mistakes, there's just happy little accidents, and the worst thing that we can do is learn a whole lot from them. And fortunately in cannabinoid medicine, that's the truth. These substances are so safe and non-toxic that even gross errors are typically safe, and we can learn a whole lot from them. So it's really wonderful to be experimenting clinically with something with this type of safety profile. And just to show you, morphologically, some of these medicines can look exactly the same but have vastly different therapeutic effects. So here we have a flower that's mostly THC dominant. Here we have another one that's about half and half THC and CBD. And here we have another one that's almost all CBD and no THC. So for the people that in this room that aren't actually handling the plants, please know you can't tell by looking at it or smelling it what effect it's going to have on someone. We really need the analytics to look at the medicine and understand what it is. So also solving some of the biggest problems we had practicing cannabinoid medicine, I came out with healer.com, which is a patient education website. Unlike other types of medicine with cannabis, I can't tell a patient, here, take 10 milligrams 3 times a day. I might be able to say that as a starting dose, but really cannabinoid medicine is highly individualized, and a lot of it needs dose titration and feedback with a provider, and most clinicians don't have the time to do that with their patients and don't have the experience that I had that allowed me to do it. So on healer.com, we have programs to take someone who's never used cannabis before, who doesn't even know what it is, and walk them through it, kind of hold their hand and introduce them to it. We have programs to take existing users who are maybe using it recreationally and want to start using it to promote health, using it medically. switching from inhalation to tincture, non-psychoactive strategies, and other programs that can help patients. It's free, so I invite you to check out healer.com and share it with your family, friends, and patients. So Maine has a wonderful medical cannabis program, one of the best in the country. We have 13 indications. We'd like to see more, but all the major indications are on there. MDs, DOs, and MPs are allowed to certify. We have 8 dispensaries and over 2,000 caregivers. Home grow is allowed, which I like. People can grow outdoors in the summer and potentially produce enough medicine to last them the whole year. Donations are allowed, so if a patient or a caregiver has surplus, they can give it away freely without an exchange of value, which is quite nice for the altruistic type of feeling that we get with cannabis in the cannabis community. Out-of-state reciprocity, so we have a lot of patients from Massachusetts coming to Maine to access our program. I'm getting mainstream referrals from the medical community all the time. We have 4 pediatric neurologists in the state. They are all sending me their toughest cases. And we have a collaborative grassroots activism environment. And I just want to thank people like Catherine Lewis from Medical Marijuana Caregivers of Maine and Glenn Peterson, both in the front row. These are fellow Mainers. We work together to create this good program, and that type of collaboration is essential. So dosing by the milligram. I have found in my practice that for the most part, the effective oral dosing range goes from 0.05 milligrams per kilogram per day all the way up to 30 milligrams per kilogram per day. So this would be like someone my body size taking 3 milligrams of cannabinoids a day and doing well versus taking 1,700 or maybe even 2,000. I will say it doesn't make a lot of sense to dose adults by body weight. These compounds do go to the nervous system, and I think our nervous systems all have pretty similar weights. But in pediatrics, we certainly need dosing per kilogram. This is such a broad dosing range. We really don't see this with other medications, but we're still in a very safe range. As some of you know, researchers have tried to kill animals with high doses of THC, and they simply haven't been able to do it, including at 300 times the dose that I'm seeing in my practice at the high end. Let's see, we've got a little pointer here. So what I've also observed is this biphasic or nonlinear dose-response curve, where if someone starts at a low dose of cannabinoids, whether it's THC or CBD, and this isn't every case, but a lot of cases follow this trend. As they titrate up, they'll get increased efficacy up to a certain point, and beyond that point, they'll start to lose efficacy. Everyone seems to have somewhat of an optimal dose, and I can't tell an individual what their optimal dose will be. They'll have to find that out for themselves. So instead of recommending a dosage, I recommend a methodology for how to find your optimal dosage, and that seems to work well. The vast majority of our existing cannabis users come here, and what we do for them is actually reduce their dose so that they can increase efficacy. Not only that, they're saving money and reducing side effects. This is well known in the animal research. So this is a study on locomotor activity in rats giving THC. And you can see from the baseline, a very low dose of THC, 0.2 milligrams per kilogram, actually decreased their activity level. Then as the dose increased, activity level went up. Then as the dose increased again, activity level went down again. So this is kind of a triphasic dose-response curve. What's interesting is that at these higher doses, 5 milligrams per kilogram, they weren't actually seeing the same efficacy at these ultra-low doses, but they were seeing the emergence of a side effect, in this case, catalepsy, which is remaining still in an unusual position. So I see this with my patients. We can get efficacy at higher doses, but often at lower doses, we get better efficacy with less side effects. And I believe that not many people in this field are dosing as low as I am. This is also well established in human data. Here's a trial using Nabiximols, a 1-to-1 ratio of CBD to THC in patients with poorly controlled pain already treated with opioids. And here you can see from baseline the dose, the group that was getting 20 milligrams did much better than the group that was getting 52 or 83 milligrams. Less can be more with cannabis. It usually is. The Entourage effect can also change the dose-response curve. This was a study from 2015 in rats looking at pain and inflammation, and it showed that a full plant extract of CBD performed better than the individualized CBD molecule. And with the full plant extract here on the right, we didn't see this biphasic dose. It just kept getting better and better as the dose went up. So the whole plant entourage, I think, can really change the dose response curve. And if we have the whole plant entourage, again, I believe that we can get better results at a lower dose. So for the patients that are on too high of a dose, I developed a 6-day protocol that gets them to lower their dose. It includes 2 days of cannabis abstinence, 3 days of very careful titration, and on the 6th day, they go to the dose that gets them the same benefit they had previously. And usually they've reduced their dose by about 50%. Doesn't work for everyone, but it works for most people. So they're using less side effects, saving money, feeling more functional. There is supporting evidence to this concept of sensitization to cannabinoids, and most of you probably have your own supporting evidence. I think most people, for the first time when they try using THC-based cannabis, whether it's in high school or college or whenever, they don't feel anything the first time, and it's the second or third time that they feel it. Maybe there's a sensitization process going on, or maybe they're just becoming more aware of what those psychoactive effects are like and how to describe them. Either way, I think thank John McPartland for these 3 references here, and this first one that just came out this year. So 48 hours of abstinence is enough to return cannabinoid receptor levels to their baseline after they've been downregulated due to THC tolerance. But there's also evidence that THC can actually upregulate the endocannabinoid system at certain doses. Another experience that I've had with THC, especially in cannabis-naive patients, is this widening of the therapeutic window over time. So with any medicine, we have the effective dose, and we have the dose that's going to cause intolerable side effects. That's the therapeutic window. With THC, first of all, cannabis-naive patients are much more likely to have side effects, whereas regular users have much fewer side effects. But over time, THC can widen its therapeutic window. People tend to build tolerance to the effects of THC at different rates. And usually people will build tolerance to the adverse effects faster than they build tolerance to the beneficial effects. So we can use this understanding in our plan with patients to help them get better efficacy with less side effects. There's also bidirectional effects in cannabinoid medicine, and we see this all over the place. Cannabis, as Martin Lee described it, is a dialectical substance or dialectical medicine. So first of all, the same medicine can have opposite responses in different individuals. So you give it to someone that's anxious, it might make them less anxious, but you give it to someone that's relaxed, it might make them more anxious. That's an old study with THC from '71, but we see this all over the place. I give 9 out of 10 people one strain that gives them energy, and the 10th person, it sedates them. And it's all over the place in cannabinoid medicine. It happens within the same individual, the same medicine, the same dose. Give it to someone in a relaxing environment, and they'll get even more relaxed. Give it to someone in a stressful environment, and they'll get more anxious. Also, the different doses of the same medicine in the same individual can cause completely opposite effects. And with cannabis overdose, especially orally, we tend to see the symptoms that cannabis would tend to treat. So if at a low dose, it might reduce anxiety, reduce pain, reduce nausea. At a high dose, it'll cause them to get anxious, experience pain, and start vomiting. So one of the discoveries that I made a couple years ago came from a mom who came back with her seizure child and said, this CBD is really working well to reduce seizures. We had just started the lab up, and I said, well, let's find out what's in that CBD and how much of the CBD they're actually getting. So we ran the test, and we found that there was no CBD in the bottle. There was also no THC in the bottle. And there was quite a small amount of THCA. And this was a very surprising finding to me. So probably 99% of the research on cannabinoids as they act on animal physiology has been done on the neutral compounds that have been decarboxylated. This, sorry about that. This carboxylic acid group decarboxylates when exposed to heat. And so all the smoking, all the heating, and so forth changes the acidic cannabinoids to neutral. There's a little bit of evidence about the therapeutic effects of THC, and it's actually summarized beautifully in a paper, on a poster that's downstairs. Thank you to the author of that poster. But for one, there's really no psychoactivity, especially at these doses, which are relatively high doses tested in animals. We also know that THCA suppresses tumor necrosis factor alpha, which is an inflammatory mediator that's part of the process of many different conditions. It's both THCA and CBD are COX inhibitors, so they have these anti-inflammatory properties. And interestingly, CBDA is kind of a COX-2 selective inhibitor. But we don't know too much more of that. So a couple interesting studies from 2013 came out looking at THCA to reduce nausea and vomiting behavior in rats that were treated with lithium chloride. And what they found was that these tiny doses, 0.05 milligrams per kilogram of body weight of THCA, reduced the gagging episodes significantly, whereas 10 times that dose of THCA didn't improve efficacy, and the same dose of THC did nothing. Actually, it was 10 times this dose of THC that did something. So the researchers found, wow, 1/10 of the dose of THCA can actually suppress this nausea and vomiting. And the next study they did actually switched over to microgram dosing. So this 0.05, this is 50 micrograms per kilogram. They repeated the study using even lower dosages of CBDA and found that 1 microgram per kilogram of CBDA could reduce seizures. This is tiny, tiny dosing of the raw cannabinoids. Now, thank you to Ethan Russo for providing me this photocopy of or scan of the paper from 79, showing that relatively high doses of THCA had an anti-convulsant effect in mice, 200 and 400 milligrams per kilogram. So what I'm seeing clinically, I'm going to present to you now regarding ultra-low doses of THCA. So this was a 5-year-old boy who failed 6 anticonvulsants, ketogenic diet, and a frontal lobectomy. He had both autism and seizures. They came to me from out of state. They had illegally tried CBD, THC, and THCA, all without efficacy in this dosing range, 2 to 5 milligrams per kilogram per day. And that's similar to what you've heard some of the other presenters describe today. So I thought, I've seen some responses to ultra-low doses of cannabinoids. Let's try that here. Let's decrease THCA to, I was shooting for 0.05 milligrams per kilogram per day. But instead of taking the 0.3 milligrams of THCA 3 times a day, the parents made a happy little accident and gave it just once a day. And so this is 15 micrograms per kilogram per day, and the seizures totally resolved. So we're talking about 1/3 of a milligram once a day of THCA, seizures resolved. They doubled the dose, and the seizures recurred. They cut the dose down again, and the seizures resolved again. Hard to believe, but what I've found is that that previous dose response curve that I described is here, and ultra high doses, by the way, can be very effective in different conditions, but I believe that there's a dose response section, a curve way down here in the microgram dosing range that's actually effective. Not for everyone, but for many patients, and most of us clinicians are probably starting here. Some of us clinicians are probably starting here or here, and we're missing this whole low part of the dose response curve. So there's also evidence that THC can have effects at these microgram doses. This was mice. THC given 2 hours before myocardial infarction improved fractional shortening, troponin leakage, infarct size, and inflammation in that area. So cannabinoids in tiny doses can do things physiologically that are quite powerful. Here's another case, a 13-year-old girl with Dravet syndrome, failed about 20 drugs, vagal nerve stimulator, ketogenic diet. She had tried CBD and had some initial improvement in cognition, but anything above this very low dose would increase her seizures. They found that THCA at 80 milligrams per day was the best treatment and overall had about 90% seizure reduction. And I want to thank Dr. Gaetanis for connecting me with this patient who made a profound influence on my career and my life, and he cared for her for almost her whole life. THC, also this family were pioneers in using THC as a rescue to abort generalized seizures. Rubbing 10 to 20 milligrams of THC into the gums or using it rectally would abort the seizure within less than a minute, sometimes just seconds. Really powerful. And of course, there's all the neuroprotective aspects of THC on board for the seizure recovery. Now, interestingly, while she was using THCA, they switched strains and found that the subsequent strain was not as effective as the previous strain. So we said, well, get your hands on both. We want to test this. So they tested both, and what we found was that the strain that worked had very high levels of linalool. Linalool is a terpene that's found in lavender. It's known to have sedating properties and also, in a couple studies, anticonvulsant properties in animals. So you can start to see how the entourage makes sense when working with these terpene compounds and cannabinoids. This strain worked well. The other strain worked somewhat, but this worked the best. And just a little tribute to Cindy May, who died a few weeks ago of sudden unexpected death in epilepsy. And we continue to learn from all that she taught us. She was an incredible patient, and I'm just so honored to be part of her path. So the last case that I'll present, a 5-year-old with epilepsy having 2 to 30 clusters of partial seizures every day, plus a tonic-clonic seizure each night, failed a few drugs. And so we started THC at this new low dose, that was about 0.05 milligrams per kilogram. So this is 1 milligram of THC twice daily, had an immediate effect, 4 days seizure-free, right after starting that. It's so surprising that 1 milligram can have this powerful effect. We went up to 2 milligrams twice a day. All the seizures resolved except for that nighttime seizure, which was now averaging every other night instead of every night. And currently, this family's tapering valproic acid. They've went from 625 down to 125 milligrams daily. We increased THCA a little bit to control seizures, and he's doing well. They're very happy on the lower dose that his hair is growing back. So that this family is very enthusiastic. So some of my take-home messages: there is an extraordinarily wide and safe effective dosing range for cannabinoids, and I encourage clinicians and also the people that are designing experimental trials to explore the edges of this wide effective dosing range, because there's some really interesting results. We have these multiphasic dose-response curves. We see bidirectional effects in cannabinoid medicine. It might be a pain to control for those in clinical trials, but I think we have to understand how this medicine works. Very promising results with acidic cannabinoids. I encourage people to try them, and of course the improved efficacy with the synergy of the phytoconstituents. Thank you very much.